Here's a environmental emergencies quick overview that should give you, should hit the key points. Speak up and ask any questions that you have, and I'll make up something to give you an answer. But this should give you what you need. That combined with what you've prepared from the book, you'll be in great shape. So I will start with cold illness or cold emergencies. It can be localized or it can be systemic. So frostbite, frost nip, trench foot, also called immersion foot. Those are all localized to the point that skin can actually freeze, just like you put it in the freezer at your house to make a popsicle out of a finger. Digits are the first thing to freeze, and then so that would be fingers and toes, and then moving it, and then nose. You see quite a bit of frostbite on noses in areas where you have somebody who's really exposed to the cold. We live in an area here, this isn't meant to be an Amarillo course, though it is. We live in an area where it is entirely possible to see a patient with profound systemic hypothermia or with frostbite, and during one season, and then it seems like just the next day, because the seasons change back and forth every 30 minutes, but maybe even just a couple of months later. So you could have somebody in March who had frostbite. You don't see it that often, but there is potential to see somebody with frostbite in March during one of those late blizzards that comes through, and then 2.5 months later have a patient who's had a heat stroke. So there are areas on this planet that it seems like you get all 4 seasons in one day, but you can definitely see these environmental emergencies spanning from one extreme to another in a short time. First thing to do with patients who have a cold related emergency is to remove them from the cold and protect them from further exposure. I said the first thing. Let's back up. I would say preceding that, number one, if we remember our patient assessment algorithm, scene size up, scene safety. Part of scene safety here is protecting yourself from the elements. So you always need to, and some of the people who think they're slick and they're old pros and they don't even need to have a jacket while they're on shift, because I never get cold. You're not there to make them happy. Take the gear with you that you might need during a shift when you're working in the field. And there are times that
come here,
you need a short sleeve shirt and a parka. So,
hello?
Oh.
Come here.
I can't hear you, buddy.
Okay, let's try that. Let's see. I tried to do a mute all and I muted myself. Sorry about that. Okay, take the gear that you need for your that you could potentially need for your shift. Tennis shoes aren't a great idea in EMS. Even the ones that you can polish and they look nice, that they don't protect your feet well. You need boots. They don't maybe they don't look as cool, but that is the way to go. And then you're going to have the footwear you need to protect yourself during a shift. Layers. We talked about this at the very beginning of the course. Everybody knows how to layer up. If you don't, you need to learn to before you hit the streets. Okay, so protect yourselves. Protect your patients from further heat loss, further exposure. So what do we do with them after we remove them from the environment? If we have patients with frostbitten parts, body parts with frostbite, we're only going to rewarm those body parts if they're not going to be re-exposed to that cold environment. That's so we have to leave fingers, toes, noses, hands, feet in a frostbitten or frozen condition until that patient is definitively removed from that environment, and then we can rewarm. Okay, we rewarm hands and feet, fingers and toes by immersing them in water ranging from, your book says 100 to 112 degrees Fahrenheit, 38 degrees to 44.5 degrees Celsius. Normal human body temperature, which is kind of an average, but normal temperature is considered to be 37 degrees Celsius. So if you look at it that way, we're going 1 degree above normal body temperature, and then maybe pushing that on up to that 44.5. I think that would probably be a little bit hot. I would try to stay closer down to that 38 to 40 probably. That's personal preference. Okay. Our first priority with hypothermic patients is to stabilize their vital functions. We have to be sure that we don't handle hypothermic patients roughly. Hypothermic patient would be a patient whose body temperature has fallen extremely low. We're talking getting our patients down to 30, 32, 34 degrees Celsius. Your book breaks that down into mild hypothermia, moderate hypothermia, and severe hypothermia. Rough handling of a hypothermic patient can cause that patient to go into VFib. So, and that hypothermic heart may or may not respond to your AED, to your defibrillator. So smooth handling Smooth movements. What do you do about a bumpy road? Try to avoid all the bumps you can. If you're treating the patient, then you need to communicate with your driver and explain to them why you need the smoothest ride possible. That's the best you can do. Sometimes we have to go back into remote places in a search and rescue type situation, or even with ambulances, and the drive out of those remote places can be really rough, and it may be the terrain and the weather may be such that we can't get a civilian helicopter in there to extricate the patients from the environment and transport them. So do the best you can, use common sense. If you don't have common sense, find a way to get some. Not sure that's a learned trait, but okay. Here's let's see, what else did I want to hit there? Moderate to severe hypothermic patients, and you can look in your book and see the core body temperature parameters for those two. Don't rewarm those patients. They're at when only basic life support is available, they are prone to developing dysrhythmias or arrhythmias, aberrancies in the electrophysiology of their heart. And at the EMT level, we don't have the capability to treat that with medications, so we don't want to rewarm them. How do we, what body temperature, how are we getting this body temperature that I'm referring to? I'm not talking sticking a thermometer under their tongue or taking a little thermometers like we've all been zapped with lately and shooting their temperature on their forehead. This is a core body temperature, and in our world in EMS, that is a rectal temperature. Just a quick go by to get a feeling for your patient's core body temperature as to whether it's really cold or really warm. You can expose their abdomen. What's that? Just pull their shirt up, and right below their umbilicus, you just pull your glove back a little bit and put the back of your bare hand. If there's blood and body fluids there, don't be doing this without cleaning it off. But put the back of your hand on their lower abdomen, and you can get an idea of whether they're extremely hot or extremely cold, and that will do in your primary survey until you can get the core body temperature when you get vital signs. So that's how you're going to know what you're working with. All right. Moving on. The old saying, which is true, don't consider your hypothermic patient dead until they're warm and dead. So local protocol is going to dictate which patients are going to receive CPR and resuscitation and defibrillation in the field. But that's been the saying in medicine for ages. What does that mean? That means you can have an extremely hypothermic patient. I'm talking a patient maybe with a heart rate of 20, and they take them to the hospital. They rewarm them. They manage any cardiac dysrhythmias that are a side effect of the rewarming process, and many of those patients, they may lose fingers and toes, and they might lose their nose. Maybe they can get a Michael Jackson nose, right? You might not remember much about him. Anyway, they may lose digits, they might lose their nose, they may lose the pinna of their ear, and they may come out looking what people would say looking kind of strange, but they may have normal cerebral function. They might cognitively return to a normal life. So we're not going to make that dead on the scene call. So what do? Contact medical control, do a good job of describing what you're looking at, and let them advise you. They will, in all likelihood, want you to do CPR and transport a really cold person, unless they're just complete popsicles. So, okay, so we hit that already. So, body temperature. Our body does a really good job of regulating body temperature to maintain body temperature of around 37 degrees Celsius, 98.6 you were familiar with before you took this class, probably. And our body loses body heat, loses body temperature by conduction, convection, evaporation, radiation, respiration, convection. Or conduction. Let's say your patient is, let's say we have a homeless guy without a coat, and somebody gives him some booze to consume because that will warm him up, even though he doesn't have a coat. And he slams that down, and he decides that he will lie down on the concrete and sleep. And conduction, the heat moving away from, because he's on that cold surface, that his body heat is going to move away from him, and that is going to cool him down. It doesn't even have to be horribly cold outside for that to cause hypothermia. I guess it would be a type of conduction. Other than dead, the most hypothermic patient that I've treated in my career was a man who somehow ended up unconscious, lying in the gutter of the curb and gutter in a really nice residential area when there was an overnight thunderstorm, and there was lots of runoff cold water running over him, and he was down in the 30 range, 30 degrees Celsius range on core body temperature. Convection, that if just think of standing in a cold room and without a jacket on, like a walk-in freezer, without a jacket on, and convection is the movement of body heat away from the person standing there, and that cools them down. Evaporation's good for us in the summer when we're mowing the lawn, if we're not in an environment that has high relative humidity. Most of the time in our part of the world, you go outside, you start to mow the lawn, or you go for a run. I don't do that anymore. You go outside and you begin to sweat, and that perspiration and evaporation is one of the mechanisms that our body uses to cool down in a hot environment. So that's a good thing. Radiation, that is losing body heat into the environment. And then respiration, as we exhale, we lose body heat from exhalation. When you're in a really hot environment, that's good. When you're in extreme cold, that's bad. Remember that the head is a source of tremendous heat loss in the body. So cover your patient's head. If it's cold outside, if it's hot outside, uncover their head as you package them for transport. And then wear your hats out there, kids. That's where you're going to lose your body heat and possibly develop a cold emergency yourself. Okay, that's stumbling through, but we got a thumbnail sketch of all of that. Okay, heat loss. I'm sorry, heat illness. Your book talks about 3 forms, I believe, at least in my education experience, that covers all of them. Heat cramps, heat exhaustion, heat stroke. If you've ever had a heat cramp, you know that it is a very painful muscle spasm, likely caused from the loss of electrolytes, and the most common place you will find heat cramps in your patient will be in the legs and in the abdomen. You see quite a few heat cramps in athletic athletes, people who are engaged in intense physical labor and not replacing their electrolytes and fluids as they should. Your book says that we don't really know what causes heat cramps. Maybe that means nobody's done a double-blind study to conclusively prove it, but I think that anecdotal evidence demonstrates that loss of fluids and electrolytes, particularly sodium, magnesium, and calcium, are all those together are the major culprit in heat cramps. How do we treat those? We just have to rehydrate our patient with something containing the electrolytes that they need. So that is, they say that sports drinks are a poor choice because of all the carbohydrates they contain. If that's all you have, use it. Water is going to further wash away electrolytes. So we don't want just straight up water. That will help with fluid loss, but it won't help with electrolyte loss. That's where sports drinks came from, Gatorade being the first. So, we all thought Gatorade tasted horrible when it first came out, because it just tasted like salts. Not the good salt, like sodium salt that I love. It's too much. So if that's all you have, go to that. There are great electrolyte replacement powders now that don't have all the carbs, and you can take a bottle of water. You all know that. Dump that in there, shake it up good, have your patient drink it. How much do we rehydrate people? Let's consult online medical control, but the old Boy Scout rule of thumb is that as long as their urine's dark rather than just a light color, very light color, light yellow color, then they are underhydrated. So consult medical control. If we have a patient with altered mental status and heat cramps, we're starting to push into heat exhaustion then. And remember, we're always careful about giving anything by mouth if because of the patient's inability to protect their airway. If they have an altered mental status, we're going to have to call ALS and use IV fluids to rehydrate that patient and replace electrolytes. So do we need to rapidly cool down a person who's having heat cramps? No. Remove them from the heat environment, get them in the shade, get them inside a house, get them in the back of your ambulance. Don't rub the heat cramp. That won't make it go away. Get them out of the heat, terminate their intense physical activity, and then use an electrolyte solution. Couldn't find it. And to replace those electrolytes, and you're going to see a good result. Not immediately. It takes a little time for those electrolytes to be absorbed and circulated systemically. And so let's see, heat exhaustion. It is in essence a mild form of hypovolemic shock caused by heat dehydration. Can it become profound hypovolemic shock? Yes, dehydration can eventually cause that. So heat exhaustion, even without becoming a heat stroke, can be the medical emergency and can actually cause someone to die. So that so you're only going to see that in the summer, right? Oh, no. Anybody ever been to your great Aunt Fanny's house in the middle of August and let's say your great Aunt Fanny lives in Amarillo and she believes in having air conditioning. She just does not believe in turning it on. And tomorrow, briefly, we will talk about the changes that cause old people to, other than financial changes, the changes that cause old people to keep their houses so stinking hot. They just absolutely do not sense heat the way that, man, I can throw myself in this category, the way us younger folks do, because, man, I was burning up last night in this house. And I was reminded of, and it wasn't, I didn't have a great Aunt Fanny, but I had an Aunt Pearl, and we would go visit Aunt Pearl, and man, there was an air conditioner. I saw it right there in her window, but it was not turned on. Maybe it was just like a movie prop. I don't know, but it was, oh man, it'd be miserable. And my dad he didn't mind heat at all. He grew up in East Texas in a farmhouse that didn't have any air conditioning. So yeah, Dad could handle the heat. He preferred the heat. And man, it was miserable to go to Aunt Pearl's. And Aunt Pearl, loved her to death. She's a great lady. She was my grandpa Brumfield's aunt, paternal aunt, I guess. And Aunt Pearl dipped snuff, not skull like put down here, the powdered snuff, and she put it up under her top lip, and she kept a spit can on her ironing board, and she kept one by her chair. And Aunt Pearl always wanted to kiss you when you got there and kiss you when you left. And man, loved the lady, but trips to her house were miserable. That was summer. You went to see Aunt Pearl in the winter, it was just as freaking hot as the summer because she cranked the heat up. But I will tell you that there is a chance that you will run calls on patients in the winter, elderly patients in the winter, who have their heater turned up unbelievably high to the point that they suffer heat exhaustion and possibly even heat stroke. One of the worst burns on a patient who lived. One of the most memorable burns that I ran, a little old lady, she stood up to go to the front door. She had a floor furnace near her front door. She turned to go back to get something, and her prosthetic hip dislocated, and she fell with her good hip on the floor furnace, and she was too weak to get up out of the floor, or physically couldn't get up out of the floor, off of the floor furnace. And she spent the night there with the heat wide open, and she pretty much baked a ham overnight. Her entire hip, and on the lateral side, all the way from her left greater trochanter to her knee, all of that muscle just cooked overnight. It was horrible, and she was still conscious, and I didn't have enough morphine to touch her pain. Oh man, that's one of those calls that sticks in my head. And it was a horrible call for her daughter. Her daughter came by to check on mom the next morning on the way to work and found her baked on the floor furnace, and you could see the grid pattern. Those of you who are familiar with floor furnaces, they have like a grid pattern that's above that furnace. The grid sits on the floor, flush with the floor, and oh man, so there are times you will see heat exhaustion, possibly heat stroke in the winter in a patient's house. So also, it's just miserable running a critical patient in a hot house like that. Man, I learned to always have my coat but not wear it, because I didn't want to go into those houses and have to take my coat off and forget it and leave it on the scene like I had several partners do. So, all right, that's enough of that. So what do we see with heat exhaustion? We see a patient who is suffering weakness. They'll tell you they feel shaky. So if they tell you, then it's a symptom, right? So they feel shaky, and maybe you even see that their hands are shaky. They have cool, clammy skin. They can be pale. They can be nauseous, have a headache. They can even be confused. We're starting to see a patient with severe heat exhaustion. At this point, have a rapid thready pulse. You'll see that early on. Body temperature can be from slightly above normal to very high, maybe even pushing 103, 104 degrees Fahrenheit as their temperature, and they can be mildly hypovolemic. They can be severely hypovolemic, and from dehydration. At that point, we're moving past the heat exhaustion, and we have to treat the dehydration and the hypovolemia, and we need to call ALS because they need IV fluids. If no ALS is available, rapid transport. First step in treating any one of these three heat emergencies is to remove the patient from that hot environment, get them inside, get them in the shade, get them inside a cool room, get them in the shade, or get them in the back of your ambulance, and again, cooling them down. If they're conscious and they can protect their airway, conscious and with normal mental status, then you can give them some fluids containing electrolytes by mouth. All right. Heat stroke, that is a life-threatening emergency. If untreated, it is, I would say, universally fatal. Your book says usually fatal. what happens in heat stroke? So why is this patient back up here in heat exhaustion? Why is that patient tachycardic with cool, clammy skin? That patient is vasodilated, and that patient is compensating for that high core body temperature. The thermal regulation mechanism of the body is still intact, still functioning, still trying to cool that patient down. When we move to heat stroke, thermal regulation has failed, and that core body temperature continues to rise and rise and rise until it actually kills the patient. You see changes in mental status that could include GCS of 3, just like my desk, right? Patient is in a coma without any response to us. And so what is our treatment? First, remove them from that hot environment. Second, we need to cool them down quickly. Organ damage, including brain damage, is occurring because of that super high core body temperature. Cardiac function is compromised, first of all, because of the electrolyte imbalances affecting the electrical conduction mechanism of the heart, and then the myocardium itself. When those electrolytes aren't present, then muscle movement doesn't happen, and the heart is a muscle, so it will cease to move. So that your patient is in an extremely life-threatening, critical situation, and it requires rapid lowering of the body temperature. So how do we do that in the field? And this is the only time that we rapidly lower somebody's body temperature. But I'm going to recommend that you take chemical ice packs and start busting those things. We're going to place chemical ice packs in our patient's groin. I always add behind the neck, in the armpits, so in the axilla, yeah, bilaterally in the axilla. I was trying to grab the plural word for axilla. I think it is axilla, but an axilla would be one, maybe. I don't know. Anyway, axillas doesn't sound right, does it? Sounds like I'm a hick. You're saying, yeah, you always sound like you're a hick. Okay. So that, and then take a sheet, put a sheet over your patient, and pour irrigation solution all over that sheet, and crank the AC up in the back of the truck, because we have to get that body temperature down. Okay. Okay, now drowning. First rule of a drowning patient is not to become one ourselves. So those of you who were Boy Scouts and Girl Scouts, you should remember reach, throw, row, and go. That should sound familiar if you were ever a Boy Scout or a Girl Scout. What does that mean? We don't go diving in without our safety being secured. We don't dive off in the water to remove a patient. I was a Red Cross lifeguard prior to, well, in high school, and kept that certification through college, and have the training and expertise to do water rescues. Turns out that Red Cross taught me reach, throw, row, and go. So there were times I needed to get a kid out of a swimming pool, and I had a little shepherd's crook thing that I could stick out there and get them to grab, or hook around them and pull them in. I never had to go in the pool after a kid. I always had a way to, or anybody, I had ways to get them out. If they just panicked a little bit, usually, and it was a small pool in the deep end, so that makes a difference too. But could just lie flat on the concrete in a prone position, hold my arm out and pull them in. And then water rescues in EMS for me, there were several times that I stripped down to my uniform pants and socks and t-shirt and went in the water after somebody, but I had a rope tied around me and I had an anchor on shore who could pull me in if there was a problem. So without proper training and without proper equipment, we don't go in the water after somebody. So past protecting yourself, the next step in caring for a drowning victim is to not become one yourself. Other things to remember with drowning. Actual drowning is suffocation by water, is the definition that your book uses. Pretty close to that. That may sound like the Texas Panhandle version of it, but it's suffocation by water. Just a water emergency is what I was referring to. Looked like someone in trouble that we're able to remove from the water if we just happened to be there, or when I was a lifeguard and I could pull somebody in who was scared and in trouble. That's also throwing a buoy. Those things it's mandated by law that any pool other than a private pool has to have one of those floating buoys that you can throw. I've spent hours in Boy Scout lifeguard class and life-saving class in Boy Scouts, as well as my Red Cross lifeguard class, practicing throwing those stinking things. I don't think I ever had, I probably did use one. I don't know. It doesn't matter. Okay. We need to remove the patient from the water. Any unconscious, we're going to treat any drowning victim as if they have a spinal cord injury. What does that mean? Full spinal immobilization. When do we apply it? Before we take them out of the water. So safely get wet and remove them from the water. Hypothermia is also, there's also a high likelihood of hypothermia in a drowning victim. Even a heated swimming pool is cooler than body temperature usually. So there would be some loss of body heat. Not a great deal in a heated pool. An unheated pool, this fat boy ain't going in one unless I have to rescue somebody, because they're cold, man. Even on a hot day, they're cold. All right, so we need to remove them from the water with full spinal precautions. And so this patient, a drowning patient, is going to have lungs full of water right off the bat, right? Wrong. There is a reflex that in the upper airway, what divides the upper airway from the lower airway? The larynx. What is the structure within the larynx that allows me to bore you right now? That's my vocal cords, right? So when water hits the vocal cords, there's a protective reflex that is called laryngospasm. It's exactly what it sounds like. The vocal cords spasm, they contract and spasm, and they stay contracted, which means they're closed. That, for a time, keeps water out of the lungs. And it's quite possible that your drowning patient will have clear lungs, will have no water in the lungs, but they suffocated due to that laryngospasm. So we'll add that to that definition of suffocation by water. So really what I should have said, and I did this on purpose, what I should have said is drowning is suffocation most often, drowning is suffocation due to laryngospasm secondary to water triggering the reflexive action of contraction of the vocal cords, right? So that would be a pure definition of that. I think you get what I'm talking about. So that is drowning. So what eventually that person goes into cardiac arrest. They're eventually deprived of oxygen long enough that they become unconscious, and they go into cardiac arrest. Eventually, that laryngospasm will relax, and that's when you get water in the lungs. So it is important that we can remove the patient from the water, suction their mouth out, and then we don't turn them on their side or do the weird pumping things with the legs that you see in all these old movies. You remove them from the water with spinal precautions, turn them on their sides, suction their oropharynx out good, start bagging them. If you bag and you have horrible bag compliance with no breath sounds, there's still a laryngospasm there. What do? Start chest compressions, and that's what you do if they don't have a pulse. Start chest compressions, and that laryngospasm will eventually relax, and then you'll be able to ventilate the patient. How do you know when it relaxes? Reassess. Always be working that airway. Okay. Questions about drowning? That's the Reader's Digest version of it. You guys may be too young to remember Reader's Digest too. Scuba diving emergencies. You have ascent, or you have descent emergencies, and you have ascent emergencies. The bends is an ascent emergency that's caused, we're not going to go into all of the, in the advanced class, I'll go into all of the gas laws in physics that come into play here. But during a rapid ascent, what's happening to the pressure? Well, let me back up. I'm sorry. As a person with scuba gear dives down to a depth, what happens to the pressure around that person? It increases. The deeper you go, the more it increases. And once that a person gets to, let's say, around 100 feet, around 30 meters, 35 meters, they have to, during their ascent, they have to pause at different safety check depths. I'm not a scuba diver, so I'm doing the best I can. If we have any scuba divers, I wouldn't mind the help. But as a person ascends from depth where they've been diving, they have safety checkpoints. They have to stop at that point, hang out there for a while. That's why you have to have lots of oxygen reserve in the dive, I guess. There are formulas for all this stuff. But have to hang out there for a while and let the body acclimate to that pressure, and then come to your next safety check. The deeper you dive, the more safety stops you have on the way up, so that your body has time to acclimate to that decreasing pressure as you ascend. If a person just panics and swims from the deep water, we're not talking swimming pool depth. We're talking like 100 feet or more down. As that person just rapidly swims to the surface, there is a risk of developing the bends. Nitrogen bubbles actually cause an air embolism, one place that is felt, those air emboli are felt, is in the abdomen, and that's because of blockages in the mesentery. Well, the mesentery, remember, are that's the arteries and veins that perfuse the intestines, that perfuse the colon and small intestine, that those originate in the abdomen, in the vasculature in the abdomen, and extend down toward the core and connect and perfuse the small intestine and the colon. It's the best I can do with that description, but those nitrogen bubbles that cause small air emboli hammer that mesentery, the mesenteric arteries, and that lack of perfusion of the intestines. That's where the term bends comes from. We also have nitrogen bubbles that cause potential for pulmonary embolism from it. So those are, and then horrible joint pain. That nitrogen moves out into joints of the body, and a patient has horrible joint pain, intense abdominal cramps, potential for a respiratory emergency due to pulmonary embolism. And how do we treat that? How do we treat that? With supportive care. We're gonna manage ABCs, call for ALS if available, but definitive treatment for this is a hyperbaric oxygen chamber. In a hyperbaric chamber, that person can be sealed up in the chamber, the pressure increased within that chamber to take them down to the depth of their dive, and then slowly decrease the pressure, just like a controlled ascent with safety checks would be. And that's how this is definitively treated. Okay. And then we, let's see, your book talks about drowning, secondary to hyperventilation, and they list that with dive emergencies. Someone who doesn't know what they're doing before they do just I'm not talking a scuba dive, I'm talking just what I would do is take the deepest breath I could, and then dive under the water and swim. People who don't know that that's the proper way to do it sometimes will hyperventilate themselves prior to diving, and that hyperventilation can cause them to actually go into respiratory arrest, and that respiratory arrest can lead to cause them to go into a respiratory alkalosis, which can cause them to go into a respiratory arrest as the body's way of compensating with that high pH level. And that respiratory arrest can then lead to unconsciousness, and when you're unconscious, you obviously can't swim any longer, and that can cause a drowning. So that's listed with dive emergencies in your book. Okay, let's see. Diving, what else do we need to talk about there? Review that in your book. I doubt you're going to see much of a question about that. Okay, poisonous spiders, black widows and brown recluses in North America. Black widows have a type of neurotoxin in their venom, and that can cause nausea, vomiting, severe pain at the injection site where the stinking thing bites you. There are people who are allergic to black widow bites, or stings. I don't know what I guess you call a spider bite. And they can actually have an anaphylactic reaction to a black widow spider bite and require the treatment that we learned way back up there. It seems like forever ago, doesn't it, when we talked about when we practiced in lab dealing with patients with anaphylactic reactions, and when we talked about them in class. So you know how to treat that. I don't need to go into that. Brown recluse bite, brown recluse or fiddleback spider, they have a cytotoxic poison. So black widow has a neurotoxic poison, should never be enough to kill an adult. I don't think it would kill a child unless the person, large or small, has an anaphylactic reaction. Then brown recluse has a cytotoxic venom or poison. What does that mean? It kills cells. So brown recluse bite, sometimes the person doesn't even feel the bite, but hours later they notice this blistered up place on their at the side of the bite, and then the blister pops and they have a concave type wound, and then skin just starts to rot. Why? Cytotoxic cytocells. That poison is killing cells. Very unlikely to kill a person unless you had, and these are isolated creatures. I don't know how they get together to procreate, but you don't find these things in herds or whatever you call a bunch of them. So you're not going to find a patient who's covered in brown recluse bites, I don't think, unless they've been crawling all through the deep dark crevices of an attic and they just crawled through naked, and they crawled through tons of them. They bit them all over, and they have 43 brown recluse bites. You don't see that. Notice the word recluse in the name of the spider. They're very reclusive. I always shake my shoes out of my lawn mowing shoes. They love to crawl up in dark places, and I don't want to have a brown recluse bite on my foot. All right. Poisonous snakes. We know about rattlesnakes in our part of the world, coral snakes. That pit vipers are a classification of snake. They have fangs. They have various types of poisonous venom. For the most part, whether we're dealing with a cottonmouth, a rattlesnake, or a copperhead, and that would be your pit vipers in North America, that is a cytotoxic type venom. An eastern diamondback rattlesnake has venom that's more of a neurotoxic type venom, and it's designed to overwhelm the nervous system, and it can actually cause respiratory arrest and death. Other than an anaphylactic reaction to the bite in an adult, rattlesnake bite is very destructive to local tissue, can cause severe nausea and vomiting. It could cause an anaphylactic reaction, but the systemic effects are more limited. Be familiar with anywhere you work, anywhere you live, be familiar with the snakes and poisonous spiders, etc., in your area, including treatment for those bites. We don't cut the site of a pit viper bite anymore and suck the poison out, even with one of the little suction cups. We're going to put a splint on it, possibly, depending on your protocol, possibly put ice on it to slow the spread of the venom. Putting ice on it sometimes also increases the localized tissue death from that bite. So make sure and contact online medical control, review what your book says. I hadn't had a student yet come back and tell me they had a snake bite on the National Registry. That doesn't mean it won't be there for you. This thing's it's a giant computerized crapshoot. The computer selects the questions and then drills down based on your responses. And then coral snake has neurotoxic venom. They don't have fangs. Coral snake bites, latches on, and chews. Normally you're going to see coral snake bites on the fingers or toes. It's not an extremely large snake. They have red, yellow, and black alternating bands. How do you tell? Stay away from them if you see one. But I think it's a king snake that has similar coloring. The coral snake, red on yellow, kill a fella. So a red band and a yellow band touching one another that's a coral snake in color. They are distantly related to cobras, and they have a similar neurotoxic venom, and that neurotoxin poisoning can knock out the respiratory drive eventually, and the person can succumb to the because of that. Okay, enough of that. How do we treat the other thing is treating snake bites? We need to clean the bite with soap and water right away. Prior to all of that, scene size up, scene safety. If that sucker's still loose, stay away. If the snake's dead, we're supposed to transport it with us. I'm calling for additional resources. They can transport the snake to the ER. Now, if it's dead, I'd stay away from the fangs. Pit vipers can still envenomate you if you poke yourself with a fang, even after the head's severed, and this would be for a few hours, not indefinitely. Okay, prompt transport, clean the bite area, keep the patient quiet, slow the spread of venom. Do that with a splint. Stabilizes joint above and a joint below, right? So they can't move around as much. They go back and forth on whether or not you wrap, say, like an elastic wrap, like an ACE bandage, over that bite to help decrease the circulation and spread of that poison. Look at that in your book. And because you rarely ever run a snake bite call, they usually self-transport, or a friend transports them by POV or a family member. We don't see that many of those. So when it starts to become snake bite season, drag out your book and your protocols and review, because you're not going to remember from year to year probably. Okay. There is antivenin, which is a medication derived from the individual types of venom that these poisonous snakes have. So antivenin is the medication. It's more commonly available for pit vipers in the U.S., with the eastern diamondback having less availability. May have to be flown in to the hospital where your patient is, or driven across town to the hospital. May not be contained in their pharmacy stock, but it's much more likely to be available with pit vipers. Coral snake, there is antivenin. There's very little of it maintained in stock at hospitals. It's horribly expensive, so it's more difficult to treat a patient who's been bitten by a coral snake. They're also not normally a super aggressive snake, and they just step on them or grab them or reach right beside them and they get scared and latch on. If one latches onto you, you need to remove the sucker as quickly as possible without him biting you again, and crush his little head and keep him from biting you again, or somebody you're with, and then clean that site. They don't have fangs to envenomate. They bite. They have lots of little sharp teeth. They bite and chew, and as they chew, as they've latched on, more likely to be like on a finger or a toe. I ain't showing you my toes. They bite, latch on, and chew, and then the venom is inflicted into that site. So if one bites and latches on, remove that sucker from yourself or your hunting buddy and kill them. Not your hunting buddy. Kill the snake or throw it as far away from you as you can, and that will decrease the envenomation. All right. Okay. Tick bites, nasty little critters. They carry things like Rocky Mountain spotted fever and Lyme's disease. Someone who's bitten by a tick should, if they start to present with symptoms, need to be treated right away. If we encounter someone who has been bitten by a tick, the little suckers, they're blood suckers. So literally they are little suckers. They bite, latch on, and then they're working to get down to a blood supply. They're blood suckers. They're little vampires. That's how they exist. If we have someone or ourselves with a tick bite, need to use tweezers and remove that little devil and grab them at the base of, it's not a stinger, any of their blood sucker, and grab them at the base of that and pull them off. Save the tick for identification. There's everything from the deer tick to black dog tick, and I don't know, I'm not a tick expert, but Lyme's disease, flu-like symptoms, and at the site of the tick bite, your book shows a great picture of it. It's like a target or a bullet. I mean, like a target type concentric ring, and around that site, around that bite site, and that's indicative of a tick bite with a tick that spread Lyme disease to someone. So if you see that bullseye or target type lesion with flu-like symptoms associated, in all likelihood your patient has Lyme's disease. How do we treat that? Support the ABCs and transport in position of comfort for treatment at the hospital. And you may encounter these patients. They may have generalized weakness to the point they just can't get up and go. Lyme's disease also can result in an autoimmune disease that's similar to rheumatoid arthritis. So long-term joint pain and weakness, and just very debilitating. You have lots of disabled people out there who contracted Lyme's disease and just didn't know it. Early in the process of the pathophysiology of Lyme's disease, very treatable. If it persists, and the longer that it persists, the less treatable it is. And by treatable, I mean that it's manageable and return that patient to normal function. Okay, prompt transport for any person bitten by a poisonous insect or an animal. Remember that reassess frequently. Your patient can deteriorate rapidly, including going into respiratory and cardiac arrest. Do a good job of managing their airway. And that is environmental emergencies. Let's take a 5-minute break. Oh, what did I do? Did I stop us? Okay, no, I didn't. But I need to stop recording.